Welcome to Adapt NCLEX. This is your ultimate NCLEX practice test, NCLEX practice question, like a mock exams, similar to what you're going to see on the NCLEX. This is challenging, but I believe in you. Stop the video, pick your answers, keep track of your record. By the end of this video, you master a lot of concept. Come back to this video days or 2 days before you take your NCLEX. Grab a pen and paper. Let's master this concept. If you get more than 65, you're on your way passing. Let's get to it. First question, as usual, prioritization. You know how to approach prioritization. Use B#. Divide the question into two. Figure out what is being asked and what is the changing condition. That's all. And this is aware of several clients whose situation need further workup. A client 4 hours after AAA repair and urine output of 30 ml every hour for the past 4 hours. The client admitted for what? CHF exacerbation, reporting of what? Leg edema. A client with absolute neutrophil count of 200, reporting of chills. A client with what? Diabetes, hemoglobin A1C of 9, and morning blood glucose of 200. What do you think? Stop the video, pick your answer, and then proceed. If I'm approaching this question, this is the way I'm going to approach it. The right answer is this. Why? A C. Why? Absolute neutrophil count of 200 is low. It's less than 500. That's sepsis. If there is sepsis reporting chills, this patient is neutropenic. Neutropenic precaution, bad problem. Look at it. AAA, repair, urine output, making 30 ml every hour is acceptable for the past 4 hours. That means every hour they're making 30. That's good. CHF, exacerbation, you have leg pain. There's no pulmonary issue. There's no pink fluid sputum. I'm not picking it. Diabetes, hemoglobin A1C of 9 and your blood glucose of 200. Why? Because hemoglobin A1C is not controlled. Therefore, your diabetes is not going to be controlled. This is the way you should approach it. So C is your right answer. Next question. Who need to be seen first? And this is aware of several clients. Same thing. SIDH, reporting leg edema. Roux-en-Y gastric bypass, prescribed complex carbohydrate. Spironolactone on hypertension with peak T wave on an EKG. Warfarin for DVT and INR of 2.1. Same thing. Approach it the same way. Stop the video, pick your answer. And then divide the question into two. SIDH, what do I have? Edema, gastric bypass, complex carbohydrate, spironolactone, peak T wave, warfarin, INR of 2.1. Which one you want to pick? This is the way I want you to approach prioritization. That's the easy way to get the answer. We break it down the way it makes sense. I can tell you the right answer is C. Why? If you take spironolactone, you're going to have hypokalemia. If you have hypokalemia, peak T wave, EKG changing, we got to intervene. If you have SIDH, you're going to have edema. No lung issue, no seizures. Roux-en-Y gastric bypass. You should avoid what? Simple carbohydrate. Otherwise, you have what? Damping syndrome. This is good. Warfarin, DVT. I want INR to be what? 2.1. Between 2 and 3, and you are 2.1, you're good. Therefore, C is the right answer. Prioritization strategy, NCLEX prioritization. And this is aware of what? 4 clients who present to the what? Emergency room with what? Flu-like symptoms. Client should be seen based on the clinical finding. A client with runny nose, arthralgia, and nasal congestion. A client with what? Small purple rash, taking allopurinol for gout. A client with what? Bullseye rash after 4 days of hiking. A client who received intramuscular flu vaccine 3 days ago. Who do you want to see? Same strategy. Everybody have flu. But whose flu symptoms caused by something bad? Runny nose, arthralgia. That. What do you think? Small purple rash causing flu-like symptoms after taking allopurinol. What do you think? Bullseye rash 4 days after hiking, and you have flu-like symptoms. IM injection of flu vaccine, and you have flu-like symptoms. The right answer is B. Allopurinol is a sulfur drug. If you take it, you have small purple rash, Stevens-Johnson syndrome. Having flu-like symptoms with that, sepsis. Runny nose, arthralgia congestion, it's like flu. Bullseye rash, it may be Lyme disease. And your flu, when you hike, expected. And if I give you injection for flu vaccine, you can get some flu from it also, or you may already have flu. Therefore, this patient is the right patient. NS is caring for several clients, which client situation need immediate phone call to the PCM. Client taking amiodarone, morning AST is 250. Client taking Clopidogrel, reporting black tarry stool. Client taking Enalapril, reporting persistent nagging cough. Client taking Albuterol for asthma, reporting what? Tremor after the medication. Same thing. Divide into two and see which combination is bad. Amiodarone, AST, what do you think? Clopidogrel and black tarry stool, what do you think? Enalapril and nagging cough, what do you think? Albuterol after for asthma, tremor, what do you think? I can tell you B is the right answer. Clopidogrel is antiplatelet. If you have black tarry stool, you're bleeding. Amiodarone can cause liver dysfunction. 250, not bad. At the same time, it's not a priority. Which one is the priority? Lung problem. Enalapril, nagging cough, is not angioedema. We will stop the medication or switches to what? ARB. If I give you albuterol, which is what? A stimulant or alpha beta agonist, you're going to have tachycardia and tremor, expected finding. Number 5, what is your score so far? Keep track of your score. Let me know. You can put it in the comment. And if this video is helping you, just click subscribe. If you're not subscribed, put a small content comment in the comment section to improve this channel. And let's care for several clients. Which client situation needs priority action? Client on atorvastatin for hypercholesterolemia, now with nausea. Client on IV heparin for DVT, now platelet of 152,000. Client on Clozapine for schizophrenia, now with the muscle rigidity. Client with what? Furosemide for CHF, now with what? Fainting spell went up. Which combination should worry you? You got to be sharp. What do you think? I can tell you, right answer is C. Why? Clozapine, second generation antipsychotic. If you have muscle rigidity, that's NMS, bad problem. If you take heparin, then your platelet is 150,000, that's not bad. If it's less than 150, that becomes a priority. Heparin-induced thrombocytopenia. Atorvastatin for cholesterol, you're going to have nausea. Priority, if you have dark stool, if you have dark urine, and then I know that you have rhabdomyolysis or muscle pain. Furosemide, you're going to get dehydrated, therefore you're going to have what's up. When you get upright, you feel like you want to faint. Orthostatic hypotension, get up slowly. Therefore, that's your right answer. 5 question. Prioritization. What is your score? 5. Now we're switching gears. We're going to next generation NCLEX. This is a next generation NCLEX. And I want you to be careful when you go through this. This is a multiple patient in the same. And this is what the NCLEX is asking now. Be comfortable with it. When you see it, I know you watch Adapt NCLEX, you'll be able to manage this easily. 4 patients, it look like prioritization. 1 patient, 10-year-old with epistaxis for 5 minutes. B, 12 years old with knee pain, 8 out of 10, and fatigue. 17-year-old with left flank pain, nausea, and small emesis. 12-year-old with scrotal pain and swelling with elevation of the left testicles. These are the same things, the same prioritization. Who do you want to see? That's all. Who are you going to see based on that? Whose condition is bad? Whose condition should be a problem? I can tell you D is the right answer. Why? Because if you look at it, this patient's scrotal pain, swelling with elevation of the left testicle, that's torsion. Left flank pain, nausea, and small emesis, this may be pyelonephritis. Knee pain, fatigue, it may be so many things. Epistaxis, somebody is having nosebleed. Well, there's no emergency right now. Therefore, that's the patient we see. Now, they will give you 1 patient that you got to focus and you move from one place to another. So this is what I did. This is patient D. We know he has testicular problem. This is the full history. A client presents with the sudden onset of scrotal pain, some nausea, vomit twice before coming to the emergency room. These are the signs and symptoms. That's why he came in. Now you're getting full history. He has frequent urination, slightly tachy, heart rate is a little bit higher, slightly temperature. Blood pressure is okay, 90 over 80. His lungs clear, heart fine. But when you check his groin, left groin, there's tenderness with the mastet because of the testicles that has what? Torsion, and it's elevated. Left testicle position higher than the right because he has torsion, and located in the left groin because he has torsion. I'm teaching you how to read test NCLEX case study. As you go through, you make sure everything makes sense. He has swelling and moderate tenderness of the left testicles because what? He has torsion. Those are your keys. So we have testicular torsion. These are the signs and symptoms. You have to know what to do. The next, let's review the clinical data. Which of the following interventions are indicated? Select and apply. Scroll to ultrasound, prepare for surgery, insert NG tube, insert Foley catheter, CT scan. Pick your answer. Select and apply. Which one will you do? Patient is vomiting and feel nauseated, not because they have obstruction. NG tube is not indicated. Most testicular torsion will need surgery. How do you diagnose it? Ultrasound, CT scan is not needed. You don't need to insert Foley. So A and B, right answer. Which of the following the nurse should anticipate in the plan of care? Now, this is a different patient. That's A. If you look at A is a 10-year-old with epistaxis for 5 minutes. Be careful with this kind of multiple patient. They will flip it, but you can see A. Now you got to change your mind, move your mind in a different direction. We are not talking about testicular torsion anymore. Now we're talking about a patient of A who has nosebleed, parent state, fever, fatigue, bleeding, joint pain for 3 months. You see, he's having 3 symptoms for the past 3 months. 2 to 3 times he has sore throat, and he has runny nose all the time. He get infection. He's tired all the time, easy fatigability. My child does not enjoy soccer anymore because he's tired and he keep on having infection, right? Something should be telling you. As you read the first 2 sentences, everything has to make sense. And more due to what? Frequent fall and joint. All of them is making sense from the first sentence. So that's the key concept you want to focus on. Low-grade fever, tachycardia, blood pressure is okay. Examination, alert oriented, his mucous membrane is dry, right? No active nosebleed right now. He has stopped bleeding, but there is old blood in his nose. His lung is clear. His abdomen is soft. Look at his spleen and liver. They're big. Something is telling you. Something sequestration. Something is happening to this kid. He has bruising. So he has bleeding problem. He has infection. And he has anemia problem. What do you think? Bruising with different stages of healing. This is not abuse. Don't get tracked. Now, you know what is wrong with the patient. What should you expect? Which of the following should you expect? We know he has bleeding problem. Therefore, which of these are we going to do? CBC, bone marrow biopsy, MPO, cold compression on the nose, and a hold pressure for the past for 50 minutes. What do you think? What do you think? Pick your answer and let me know. I know we're going to get CBC to find his platelet, his white count, and the RBC. It looks like he may have cancer, bone marrow biopsy. He's going to be NPO. We got to do a bunch of tests. Cold compression to the nose for the nose to stop bleeding. And hold some pressure over 50 minutes of the nose. Now, what do they have? They did the same patient, patient A. Now we know they did a bone marrow biopsy. There's a rapidly growing, overcrowding lymphoblastic leukemic cell. That tells you the patient has leukemia. It RBC is immature cells. They're not growing. The white platelet is also immature cell. White cells is all immature. His PT, INR, and PTT are normal. That means it's not a coagulation problem. This is what? A platelet problem. That's why you have petechia. This is what we call pancytopenia. Therefore, what should you expect? Prepare for chemotherapy, private room, strict an hygiene by the nurse, transfuse leukocyte, reduce irradiated blood product, disinfect all equipment prior to use, droplet precaution. Which of the following intervention the nurse should include in the plan of care? So which of this should you include in the plan of care? What do you think? Prepare for chemotherapy. This patient needs to be in a private room. Strict hand hygiene by the nurse. When you transfusion red blood cell, make sure you remove all the white cells from it, or so that they don't cause infection. You got to disinfect all equipment, and it does not need any droplet precaution. It needs standard precaution. It's not infectious. We will rather cause infection for him. Therefore, no droplet precaution. Which intervention the nurse should question? That means I got a question. On which patient? Client B. Like I told you, be careful when you're going through these multiple patients. It will confuse you. Don't fall for it. Pay attention to the instruction and read what is being given. Who is client B? Client B is a 12-year-old with a knee pain and fatigue. And now I've given you more history about the client B. Client report acute onset of what? Upper back, knee pain after hiking. Therefore, he went on hiking. Now, probably dehydrated, and now you have knee pain, back pain for 3 hours. If he's dizzy and tired because he's dehydrated, similar symptoms occur whenever he changes altitude. There is a change in altitude, patient will have similar symptoms. Respiratory infection or prolonged exposure to heat or weather, this is what happen. You get weaker, you have knee pain, and you get tired. Those are his vitals, slightly tachycardic, right? The rest of the vitals is normal. You don't have to boil down to every little things. You look at it and say, okay, within normal limit. Patient is alert oriented. His lung is clear. His abdomen is fine. His bowel is fine. He has no ecchymosis, but he has multiple joint tenderness. His joint is all adding. But when you look at the lab, it's anemic. The red cells are low, and the reticulocyte is very high because red cells are being broken down. Which condition will give you that? This is a test taking strategy. This is content. If you need more, check out that thing. But I've given you a patient, you'll be able to figure out that this change in altitude is a buzzword. Knee pain and back pain, when they get dehydrated, they have these symptoms. He's a young kid, 12-year-old. This sounds like what? Sickle cell disease, right? Which intervention the nurse should question? Now I got a question. If this is a sickle cell patient, which of these I should question? Nothing by mouth. We should let the patient eat. Now think about it. Private room. Does he need a private room? Cold compression to painful areas. Patient PCA for pain, morphine. SCDs. Loose feeding clothing. Supplementary oxygen. 5% albumin and hydroxyurea. Which of these we should question? I can tell you, number one, you got to question. They should be giving fluid. They should be allowed to drink. You got to improve their fluid to prevent vaso-occlusive disease. Which one you should question? They need a private room. They're now immunocompromised in this situation. That's good. Cold compression to painful area will cause ischemia. Patient need a PCA pain medication. Sequestration compression device will cause more ischemia, no SCDs. Loose feeding is good. They will need some oxygen. 5% albumin is not needed. Hydroxyurea is used for sickle cell, but it's used in what? Chronic condition, not acute condition. Maintenance. This is an acute problem. Hydroxyurea is not going to work. Now, match the diagnosis for each client based on the clinical finding. Now that we know what is wrong with each patient, you should match what is going on with them. That's all. What do you think? Number one, he's a 10-year-old with epistaxis for 5 minutes. We know this is a leukemia patient. 12-year-old with a knee pain and fatigue. We know this is a sickle cell, so vaso-occlusive. 15-year-old, 17-year-old frank pain, nausea, and small emesis. This is pyelonephritis, and this is testicular torsion. So this is how you go through them. Yeah, 6 questions. You see these all the time. You just have to be careful as you go through them and master them. Number 7, NS is assessing a client who sustained what? Thermal burn to 40% of the total body surface area. Which findings should the nurse expect during the emergent phase of burn injury? Select or apply. Increase urine output, hypertension, decreased hematocrit, hypokalemia, tachycardia. This is physiological adaptation. We've changed and now we're on physiological adaptation. What do you think? What do you think? You pick your answer, you stop your video. Key concept. If I'm answering this question, I focus on emergent phase. Emergent phase is a resuscitation. If I'm resuscitating you, you are in shock. If you are in shock, after burn, what do I expect? Your urine output is going to go low, no high. Your blood pressure is going to go low, hypotension. If you dehydrated, your hematocrit go up. Your potassium go high because your cells break down and you release potassium. Because you dehydrated, you have tachycardia. One answer choice. Select or apply. Don't overselect. Like I said, this may be tough, but I believe in you. You can pass it. And this is caring for a client with 45% total body surface area. Which fluid in the nurse should anticipate during the emergent phase? Normal saline 0.9%, 0.45% normal saline, lactate ringer, 3% normal saline. Concept question. Stop the video, pick your answer. Every question, I'm going to give you a concept. What is the concept you need to know? You pick your answer. I can tell you, when you have a burn injury, normal saline will cause acidosis because you're going to give them a bunch of fluid. The best fluid for burn patient is the lactate ringer. All these are normal saline. NS is caring for a client with severe burn to the face. Which of the following medication should the nurse anticipate applying during wound dressing? Sulfadizine, silver nitrate, bacitracin, mupirocin. What do you think? Silvadine, silver nitrate, bacitracin, and mupirocin. Which medication, burn medication, you use in the face? This is the NCLEX trap. Stop the video. I want you to write this down. If you get this wrong, it's okay, but I got you. You pick your answer. I can tell you, when you have a burn injury, the first medication, the best medication is Silvadine. Always pick Silvadine. But if they tell you the burn is to the face, choose bacitracin, because Silvadine will cause scarring of the face. Therefore, the best medication for burn dressing change is bacitracin if you have what? Burn to your face. But the rest of your body, large burn injury is Silvadine. Don't forget, bacitracin for the face and then Silvadine for the rest of the body. And this is what I explain here. And this is the NCLEX tip. For a large burn, use Silvadine. For a face burn, facial burn, use bacitracin. This is caring for a client 2 hours post-thyroidectomy. The client reports difficulty breathing and a stridor. What is the next priority action? Apply oxygen via nasal cannula, reassure the client and stay at bedside, prepare for tracheostomy insertion, elevate the head out of the bed. What do you think? This is a prioritization. We are on physiological adaptation. All these questions are physiological adaptation now. What do you think? Thyroidectomy. This is not just any thyroidectomy, it's thyroidectomy. When you have thyroidectomy and you have stridor, that means airway compromise. If the airway compromise, what is the best thing you should do? Oxygen is not the problem. Fix the airway. Reassuring the client is not a good thing. Elevating the head of the bed, fix the problem. Tracheostomy to secure the airway. And this is assessing the client with severe pancreatitis. Physiological adaptation. He has condition has changed and he has physiological changes due to severe pancreatitis, which finding require immediate intervention. That means prioritization, something that is going to cure the patient. Great sign on the flank, pain rated out of 8 out of 10 in the upper abdomen, blood glucose of 180, and serum amylase of that. You can tell physiological adaptation, there's changes in the condition. Everything is abnormal. But which one need immediate intervention? All of them are bad, but there's one. Major complication about pancreatitis is bleeding. Which one is bleeding? Number one. Great sign is what? Peripheral flank ecchymosis. These are bad problem. and the nurse should intervene because patient is bleeding. I expect upper abdomen, 10 out of 10, I don't care. Your glucose is going to go up because the pancreas is inflamed, and you're going to release amylase, expected finding. Septic shock, blood pressure 78/46, heart rate of 128, and warm skin, signs and shock. Which provider order should the nurse carry out first? You receive the order, patient is in shock. Draw a blood culture, give them norepinephrine infusion, 2 liters of normal saline bolus, broad spectrum antibiotic. Stop the video, pick your answer, let me know. What do you think? Concept. The right answer is 3. C. Why? Because patient is in shock. When you're in shock, hypoperfusion. What is the number one thing about shock? Reperfuse the patient. How do you reperfuse them? Give them fluid. Norepinephrine will cramp them down. It doesn't reperfuse. You got to fill the tank before you squeeze. To squeeze, you need fluid. You give them fluid, you squeeze. Blood culture, good. But what do you need? You still have to give them fluid. Broad spectrum antibiotic, you should wait until you draw blood culture. Therefore, C is the right answer. You have a 32-year-old G1, P1, intrauterine demand at 30 weeks. Baby is dead inside the mother. There's bleeding from all IV sites. There's petechia. There's nosebleed. These 3 things I've summarized it. This is a full case, but I make it in the standalone. What do you think is wrong with this patient? Temperature 100, heart rate 115, blood pressure down, and all of this. There is bars where the intrauterine demand and the bleeding from all IV sites should trigger something in your ear. This is what I call bars where. These are the things you focus on. I cannot explain everything to you, but this is what, when they write a question, these are the things you have to pay attention to. And you have petechia and nosebleed, something should tell you. Which of these you should expect? Which lab work? Low platelet, low hemoglobin, low iron, low plate, low PTT, high fibrinogen, and high D-diamonds. What do you think? When you see intrauterine demand and bleeding from all IV sites, petechia and nosebleed, this is DIC. If this is DIC, disseminated intravascular coagulation, there's consumptive problem. It's going to consume all your coagulation factors. What is going to happen? You're going to have low platelet. You're going to have hemoglobin because you're bleeding. Your iron is going to go up. Your PT is going to go up. Your PTT is going to go up. Your fibrinogen get consumed, and your D-dimers go up. If your fibrinogen get consumed, the fibrinogen go down, and your D-dimers goes up. This is what you should expect in DIC. I want you to know it and then be comfortable with it when you see it. A client with DK has a potassium of 2.8. The provider prescribed IV insulin. What is the next best action? Give the insulin as prescribed, hold the insulin and notify the provider, administer the insulin and potassium together, give IV sodium bicarbonate. What do you think? Focus on the keyword. Focus on the potassium. Potassium is low, and I give you insulin. What would you do? That's the concept. I can tell you the right answer is to hold it, because if I give you insulin and your potassium is 2.8, potassium can go into 1. You go down and you go into arrhythmia. Don't give the insulin as prescribed. You should not give insulin and potassium together or give them sodium bicarbonate. The problem is you should not give in this situation. Patient had SIDH with a serum of sodium of 118, which the nurse should monitor the client for what? Seizures, hypertension, constipation, polyuria. Prioritization. What should you think? The concept is there. I can tell you, right answer is A. When you have hyponatremia, something that is going to kill you is what? Seizures. These are our expected findings. The nurse is caring for a 2-year-old child with a what? High fever, drooling, and stridor. 2-year-old, all these things. Fever, drooling, and stridor. That means airway problem. The child is sitting upright and leaning forward. That is strapper position. If you combine the 3, 4 together, You have a tripod position patient, and then you have a fever, drooling, and stridor. What do you think? What is your priority? Assess the client throat using a tongue depressor, administer prescribed antipyretic, prepare for intubation, and notify the provider, obtain a throat culture. This is concept you already know. You just put in the case form, in the question form. You know this is sound like epiglottitis. What would you do? Stop the video, answer the question, and pick your answer and keep track of your record. I can tell you, prepare for intubation, airway compromise, airway compromise, airway compromise. Anything you put in their mouth, you're going to kill them. Tongue depressor, nothing. Throat culture, it's saying the same thing. Just treating the fever is not helping this kid. He has stridor. And this is caring for a client with what developed. This is the same question we saw. Disseminated intravascular coagulation following surgery. Which of the following is intervention appropriate? Patient has DIC. What would you do? Select or apply. Monitor the client for bleeding from IV site. Administer only IM medication. Avoid applying firm pressure to venopinchal site. Administer anticoagulant therapy as prescribed. Encourage frequent ambulation to prevent DVT. Which of this is appropriate? Okay. Which of this is appropriate? You pick your answer. You don't have to select everything. Select those that you're 100% confident. I will monitor the client for IV site. Number one, good. IM injection can still bleed. You should apply pressure, not avoid, at the venopuncture site. You should give them anticoagulation because that will prevent the cascade of consumptive coagulation. So these people, even though they're bleeding, they need anticoagulation to stop everything. Patient is bleeding everywhere. It should not work just because I said to prevent DVT. It's a trap. Therefore, right answer is A and D. A nurse and a UAP enter a room of a client with dysphagia who is eating. The nurse immediately observed the client attempting to talk but was not able to. Which action is most appropriate? You went in, patient eating, patient look like they're choking based on the description. Rewrite the question on your own. It look like I'm choking. What should the nurse delegate to the UAP? Perform NCLEX maneuver, activate emergency response system, assess the client coughing ability, check client mouth for residue food. UAP can assist you in any way they want, but you got to give them something. What do you think? Number 18 is a trap. But if I were you, I'll pick this. That's the easy thing. A call for help. You always want to call for help. Letting them do this maneuver, NCLEX maneuver, well, it's fine, but somebody have to call for help. The easy way, stay with the patient and let them call for help. All these assessments, you can do yourself. A charge nurse is making an assignment for a staff of an RN, LPN, and new graduate nurse. Which assignment is most appropriate for a new graduate? Give them somebody who is stable. A client with a new chest pain and waiting what? Cardiac catheterization. A client 24 hours after appendectomy on clear liquid diet. A client with amyotrophic lateral sclerosis with dysarthria and pulmonary embolism who started IV heparin therapy protocol. What do you think? Who is stable for the new graduate? I can tell you, this patient, stable, 24-hour appendectomy, eating, cardiac catheterization. When they come back, they need extensive workup. Amyotrophic lateral sclerosis, dysarthria, that's airway. Pulmonary embolism, a bunch of protocol. New graduate can take care of B. And this is planning care for a group of clients and considering tasks that can be delegated for a UAP. Anything that require thinking, just ADL. Which of the following is appropriate for to delegate? Select or apply. Obtain vitals for a client with stable hypertension. Assist client with hypertension, Alzheimer's to the bathroom. Feeding a client with dysphagia who has started on mechanical soft diet. Performing postmortem care for a client after RN has pronounced the client dead. Collecting a clean catch urine specimen from a client with suspected UTI. Performing initial teaching on incentive spirometer after abdominal surgery. Turning and repositioning the client at risk of pressure injury every 2 hours. A bunch of answers. It does not matter how many they give you. This is just standard seat select or apply. Who do you delegate to UAP? The principle, somebody who does not require thinking, simple. Obtain vitals for a client with stable hypertension, they can do that. Assisting a client with Alzheimer's disease to the bathroom, they can do that too. Feeding a client with dysphagia who just started on a mechanical soft diet is unsafe. Performing a postmortem care for a client after RN has pronounced the client dead, it's fine. Collecting a clean catch urine specimen from a client with the suspected UTI, they can do that. Performing initial teaching is unacceptable about incentive spirometer after patient surgery, and turning is an ADL that's expected. They can do that. Delegation. You can see we move to delegation and assignment. And as in team of RN, what is that? PN and UAP are caring for a client, which tasks can be safely delegated to a UAP. Select all. Monitor the client response to a new medication. Monitor a client use of incentive spirometer. Monitor a client for self-insulin administration. Provide stoma teaching and ablate the client to the bathroom. What do you think? A UAP, all they do is ADL and nothing that does not require thinking. Therefore, don't get trapped. I can tell you there's one word in the question that eliminates a bunch of them. You pick your answer already? Monitor, out of the realm. Monitor, out of the realm. Monitoring, out. Provide stoma teaching. They don't touch the stoma. They can ambulate the client. One answer choice. You can delegate to the UAP. And this is leading a team consisting of what? RN, LPN, UAP, caring for a client with severe liver disease related to alcohol, cirrhosis of the patient who has liver disease, and you need to assign certain tasks to your team. Which of the following tasks should be RN safely delegate to LPN? Now, not the UAP anymore, LPN. They can monitor, they can do most medication, that's MMR most. They can reinforce, they can do special tests, stomach care, and tube feed. Therefore, which one should you give it to them? They can give you lactulose, most medication, not a big problem. Assessing a client for new onset confusion, RN job. Reinforcing teaching after alcohol cessation, they can do that. Evaluate for a flapping tremor, that's hysteresis, they cannot do that. Assist with personal hygiene, even though they can do that, UAP is there, so UAP will do that. If all three are there, everybody stay in their lane. Therefore, this has to be done by the UAP. Don't get trapped. And then she's preparing to admit a client with diagnosis of varicella. What do you see? Infectious control. We finished with delegation. We finished with prioritization. We did with what? Next generation NCLEX case study. Now we're on infectious control. This is a hard questions. Like I told you, if you get 65, you closer. Use this as a mock exams. But thus, I believe in you. And then she's preparing to admit a client with a new diagnosis of what? Varicella open lesion. Varicella open lesion. That's an active situation, which next intervention is appropriate. Put them in a different category. Is this airborne, droplet, contact, standard, or combined? What is appropriate? Client in the negative pressure room. Nurse wear surgical mask. Client wear N95 mask to the radiology for chest X-ray. You know, varicella is airborne. The nurse has to be wear what? N95, no surgical mask. When patient leave the negative pressure room, they wear surgical mask. Therefore, this is that. And what is the problem? Nurse wear gown, gloves, and N95 for routine care. That's contact and what? Airborne. That's good. Client door is open. It should be closed. Sterile disposable gown for visitors. They can wear disposable gowns. It does not have to be sterile. Therefore, this is the right answer. And then that's one private room. Which client should the nurse prioritize for the private room? You got to know if it's droplet, airborne, standard, and contact. Then you assign them. Uncrusted lesion around the mouth. What do you think? Open vesicular non-crusted lesion over the entire body. Sore throat, runny nose, arthralgia, and a draining sacral wound. Put them in the different group of infectious control, infection prevention, and figure out who is in trouble. You pick your answer. I know you pick it. And I know you pick the right answer because you picked this. Because vesicular, open vesicular non-crusted lesion, that's what? Varicella. And this is what? Airborne. in addition to contact. Therefore, they should be placed first. Unencrusted is what? Contact. That's impetigo. So throat, runny nose, that's flu. It may be droplet. Sacral wound, contact. B is your right answer. Those are the answers I told you. And let's provide care for a client is dropper precaution. You want to go to the CT scan. Which action by the nurse is appropriate? Concept, what do you think? Pick your answer. I will give you the concept. You pick the concept. If you drop a precaution, patient does not wear anything. The nurse wear what? Surgical mask when taking care of the patient. When the patient leave their private room, the patient wear surgical mask. The nurse or any transporter does not wear anything. Therefore, place the well-fitted N95 on the client is wrong. Instruct the transporter to wear a surgical mask because the patient is going to wear surgical mask. B is wrong. Wear non-sterile surgical mask when preparing. Yeah, when you're in the client room getting them ready, you wear it. Ensure hand hygiene by soap and water. No, you can use hand sanitizer. A new graduate is planning care for a client diagnosed with what? C. diff, contact precaution. Which infectious control prevention the new graduate should institute? What do you think? Implement. Client wear gown in their room. Hand sanitizer for all visitors. There's a droplet precaution and a single-use dedicated equipment. If you see diff, what do you think? Pick your answer. Stop the video. Keep track. We're on 26. What did you get so far? I know you picked this because this is not a droplet, it's contact. See diff, you got to wash your hands. Client does not wear anything in their room. By default, number 4 is the right answer. And then prepare to admit a client in the emergency room who have draining sacral D-cube that ulcers who tested positive for MRSA, right? MRSA. Which room assignment is appropriate? Cohort with the client with impetigo, cohort with the client diagnosed with vancomycin-resistant enterococcal, cohort with the client diagnosed with MRSA, cohort with the client diagnosed with what? Adenovirus. There's a concept. Let me know if you know the concept. Put it down in the concept, in the question, and let me know. What do you think? Which room will you put this patient? You put them together with MRSA. This is the concept. In cohorting, it's not based on the precaution, is based on the organism. If all of them have contact, you put the same organism together. Even though some of these may be contact, right? Most of them are contact. Adenosine is contact and droplet. Vancomycin is contact. Impetigo is contact. But they are different organisms. The only person you can come together is 2 MRCs. That's the concept. Now, I know you know how to do this. If I put this in the question, will you fall for it? No, just follow your principle. Questions are things that they ask based on what you know. You know it. Don't let the point go away. What is the question? After orientation on follow insertion, you know how to insert Foley. In which order would the new graduate perform this procedure to indicate effective orientation? The words may change, but the principle is the same. How do you insert Foley? Arrange them in order. You fill the balloon with sterile water. You insert the Foley sterilely. You open the kit, then you wear the gloves in it, you clean the perineum with soap and water, you position and drip the client, and you perform hand hygiene. These questions are challenging. I intentionally did it because I want you to pass. And so when you pass this, keep on watching this multiple times and all the 85, and you'll be good. What do you think? What do you think? The first thing we do, we got to perform hand hygiene. Then you got to put the patient in the right position. You got to clean them up. Then you open your kit. What do? You insert the Foley and fill the balloon. Straightforward. And next is preparing to administer a medication for what? Nasogastric tube. Nasogastric tube. What do you think? Which of the following steps the nurse should take to provide safe medication administration? You can see we switched a little bit. The last question, that one. This is fundamentals. We're doing fundamentals, English fundamentals, things you're supposed to know, but it's all part of the test taking strategy, NCLEX practice question, NCLEX review questions, the mock exams you should know. What do you think? Crash all medication together so that it can easily be administered. Use only liquid formulation of the liquid when possible. Administer medication while the client is in the supine position and flush the tube with 50 ml water before and after administering each medication. Which one is safe? I can tell you, everything has to be in the liquid form. It's better. You should not crush everything. Some of them does not need to be crushed. Supine position is not good. Semi-filer is best. 550 ml every time you flush, that means 100 ml, too much flush. That's too much. And then she's teaching a client how to ambulate with the cane, which action by the nurse, client indicate ineffective. Fundamentals, assisted device. How do you work with the cane? Use the principle. What is the patient doing? The client advanced the cane 12 to 16 inches with each step. Client position the cane on the weaker side. Client measured the height of the cane from the wrist crest. Client advanced the cane after a step with the weaker leg. Principles associated with these fundamentals of nursing. Cane assisted device. How do you move it? That's a principle. Pick your answer. I'll give it to you. You pick it. I know you pick it. You pick your right answer because you picked this. Why? That's how you measure it from the wrist crest or greater trochanter. The second one, you should not advance the cane more than what is between 6 to 10 inches in front of you. 12 to 15, you're going to fall. The cane is designed to support your stronger side, not the weaker side. That's the confusion patient always have. So provide the teaching. Client position the cane on the weaker side. You're going to fall. The weaker side should advance with the cane together. You should not advance before you move the cane. So D is wrong. And this is preparing to administer intramuscular injection. As told you, fundamental safe medication administration. Which side is most appropriate for the adult client? Deltoid, vastus lateralis, ventrogluteal, and rectus femoralis muscle. It's always the best place to inject iron medication because you don't want to cause injury. You can be trapped because you put deltoid, but don't pick it. Big gluteal, ventrogluteal. Deltoid sometimes can be used for like vaccination because it's a very small volume. But when they say iron medication, medication is a large volume. The best place is ventrogluteal. Big muscle, big protection, less injury, best way, injected. And let's care for a client post left thoracotomy at the big surgery in the chest. The client report is paying 8 out of 10. Best care and comfort. Right? That's what we're doing now. Best care and comfort and some fundamentals. The client report paying 8 out of 10. How should the nurse assess the client pain? He said, I have pain, 8 out of 10. How are you going to assess me? Ask the client again about their pain. You don't believe them? Look for facial expression. Do you believe them? Document the client report pain exactly as described. Check for signs of what? Respiratory distress. Test taking strategy. How do you answer question? Bring your concept. Did you pick your answer? I know you pick it because you pick it. Pain is subjective. Whatever the pain the person said they have, it does not matter. If you're looking for facial grimace, that means you don't believe them. If they said they have 10 out of 10, accept it. Document the client pain exactly what they describe because it's a subjective. Next generation NCLEX. Are you ready? I know you're ready. This is another NGN. Same thing. Strategy, first 2 lines is the buzzword. When you read the first 2 lines, figure out what is going on, find the problem, diagnose the patient, and use it to answer the question. Every portion of the case, make sure it meets the criteria. So this is the way I'm going to read it. Watch it. Next time when you're reading a case study, do it the same thing. Client arrives to the emergency room via EMS. Okay, he went to the emergency room. Client reports severe headache behind the right eye. That's your buzzword. Pick it. Pain behind the right eye. Okay, I'm sticking with it. The pain is what? 9 out of 10. That's where it behind the right eye. And excruciating and worse with what? Laying down. Oh, to light and noise. report, I usually get this headache, big word. Same time, every 3 days at the same side of my head. It lasts for 30 minutes to 3 hours. There's no horror. I cannot identify triggers. That's the key. It happens every time, every day, same time, same day, and it's behind my right eye, and it lasts the same time. But there's no trigger. I don't feel anything before it comes. That's the key word you can use to distinguish the rest. What is the problem? It's alert-oriented. Nasal discharge, password. Meiosis, ptosis, mostly is the eyes, and the eyes is tearing. That means any headache located to just the eye is the key word. You have to know the difference between headaches and how you can distinguish between them. If you need it, check Adaptation, because I have a video for that. Face midline. The GCS is what? 15. No drilling, no motor deficit. S1, S2 is present. Lung clear bilaterally, abdomen soft. Therefore, what do you have? You have headache associated with behind the eyes, and I'm tearing, I'm crying. What do you think? Is this trigeminal neuralgia? Is this subarachnoid hemorrhage? Is this cluster headache? Is it migraine or headache? Tension. You go back to the case and you see, does this meet the criteria? Trigeminal neuralgia, it will tell you shooting pain in my face when I touch. There was nothing like that. Subarachnoid hemorrhage. Where's headache of my head? It's not there. Cluster headache. Oh, behind my ear, localized tearing, okay, at the same time, same day. Boom. Migraine headache, I'll get horror. I don't have it. I can feel it's coming. And the tension headache, I'll feel like a band around my head. Therefore, that's my answer. Which additional finding the nurse should expect? Okay, selected apply. If I think this is a cluster headache, what should I expect? Client will be pacing in the room. There will be a tight band pain. The pain behind the eyes, right? Nausea, electric shock-like pain when touching my face. What do you think? If this is a cluster headache, you don't see a band-like pain. You don't see nausea. This is migraine. You don't see electric shock-like pain. This is trigeminal neuralgia. The patient will be pacing because they can't stop. And it will be pain either both eyes or one eye. Therefore, this is what you expect. The nurse receives the order. Now, oxygen, non-rebreather, sumatriptan, calcium channel blocker, and NSAIDs. Which order the nurse should prioritize? That means which order should the nurse prioritize? That means how do you manage this cluster headache? You give them non-rebreather, sumatriptan, calcium channel blocker, and NSAID. The treatment for what? Cluster headache, we think is ischemia. Therefore, due to hypoxia, give them hypoxia control. And how do you control hypoxia? Oxygen. Don't give them any medication first. Give them oxygen. Now there's a new information. At 12 o'clock, the client became confused. GCS is 13. Now GCS was 15. Now down. And what did he say? This is the worst headache of my life. Now condition has changed. It's no more cluster headache. He said, this is the worst headache of my life. He has drooling and left leg weakness. That means bad problem. What do you think? This is what's original. Now he's confused. Worst headache of my life. Drooling and the left leg weakness. What would you do? What is the first next action? Do you get a CT scan, assess the client airway, perform a complete neurological exam, check their blood glucose? What do you think? What would you do? What would you do? This is the airway problem. You have stroke, bleeding in the head. We should check their airway. The CT scan was obtained for the client after airway is secure. What finding the nurse should expect on the CT? Worst headache of my life is what? Epidural hematoma, subdural hematoma, subarachnoid hemorrhage, intraparachnoid hemorrhage. What do you think? Worst headache of my life? What kind of headache do you expect? What kind of bleeding should you expect? What should you do? I can tell you subarachnoid. Epidural, they will tell you the ball, something hit their temporal area. Subdural, they will tell you they fell, they are old people. Intraperitoneal is inside the brain. Therefore, that's the right answer. The next has reviewed the clinical data. Which of the following should the nurse expect in the plan of care? Now, patient has what? Bleeding in his head. So what are you going to do? Levetiracetam, 500 milligram IV every 12 hours. Do neurological exams every 4 hours. Give them enoxaparin 40 milligram sub-Q daily. Apply sequential compression device. Antiemetic. Head of the bed 30 degrees. Suction them every hour. You see what I've taken you? I've taken you to head injury, bleeding in the brain. What do? All these things, I'm trying to let you know how to prevent ICP increase. And therefore, which of this? You give them levetiracetam, you do neuro exam every 4 hours, you give them enoxaparin, sequential compression, antiemetic, head of the bed 30 degrees, and suction them every hour. Stop the video, pick your answer, keep track of your next generation NCLEX answers, and see if you get all of them right, because that's that matter. It's matters the most. I can tell you again, give them Keppra, those to prevent seizures. Doing neuro exams every 4 hours, that's bad. Every hour is good. Some patient is bleeding in their head, no enoxaparin, heparin. You will need SCDs. You give them antiemetic so that they don't vomit, and you keep their head a little bit elevated. Sucking them every hour will increase ICP. This is that case, and that's how you answer next generation NCLEX. This is a neuro question. I know you master it. I know you get all of them right, but keep on watching it, like I told you. On my 34, let's go. Risk reduction. Risk reduction is big. It's like physiological adaptation. That means you're preventing the risk before it happens to the patient. Physiological adaptation, something has already happened to the patient. Which condition you can see, what kind of changes you should expect. Now we want to prevent them from getting before it becomes prioritization. This is what the NCLEX is asking most of the time. 6-month-old present with what? Intermittent abdominal pain, current jealous stool, vomiting, abdominal distension. A bunch of buzzwords. Put it together. You know the diagnosis because I know you see one word there that should give you the word. Which action should the nurse take? Administer antibiotic, start oral fluid to prevent dehydration, prepare for barium enema, and prepare for surgery. What is your answer? I know you pick what? Barium enema, because this is what? Intussusception. Carrying jelly stool, vomiting, abdominal pain, 6-month-old, intussusception. Best thing is to what? Decompress the kid through what? Enema. You can use barium enema or enema. Air enema is the best way to do it, but even if you don't see it, put something that has enema in it. We don't go to surgery right away. We don't start the patient oral feeds. We give them IV and then antibiotic later on. A stroke patient has hemi paralysis. He has facial weakness. The face is all bad. He can what? A non-productive cough. Which referral is appropriate? It's a stroke patient, weakness, facial weakness. It can clear his secretion, and he's having non-productive cough. You call speech therapy, respiratory therapy, physical therapy, occupation therapy. Who is going to help you with this patient who has stroke and is having these all symptoms? His airway, right? This is airway, right? So do you call a respiratory therapist? What do you think? Or physical therapist, occupational therapy? You can eliminate C and D because they talk about movement, use of hand. Respiratory therapist, if they have an actual airway, but a stroke patient needed speech therapy to help them evaluate their swallowing, probably they are aspirating. That's why they're having all this problem. And this is irrigating the client eye after a chemical splash. Which action is appropriate? How do you do it? Direct flow towards the inner canthus, that means inside. Use a cold tap water. Irrigate from the inner to the outer and apply pressure patch or after. What do you think? It's a test-taking strategy. There's two answers that are contradicting each other. Which one is the best? D and B is out. Therefore, pick one, A and C. You usually want to start from in to out so they can wash everything out. Therefore, this is the right answer. And next is caring for a client who underwent an ERCP 45 minutes ago. Which finding is most concerning? Risk reduction, ERCP, endoscopic retrograde cholangiogram pancreatography. That means I put something in your mouth, I go all the way into your pancreas. What is the most common complication? Perforation. Which of these indicate perforation? Mild abdomen bloating, throat discomfort, epigastric pain radiating towards the back, and what? Drowsiness from the sedation. You know, C is the right answer. All these are not bad. Suspected finding. And next is an emergency department is caring for a client diagnosed with what? Pneumothorax, who require insertion of chest tube. Place the following nursing intervention in that order. If the doctor needs to place chest tube, how are you going to help the doctor? That's all. What do you think? How are you going to help the doctor? How are you going to help the doctor? Apply occlusive dressing, verify physician order, prepare the chest tube drainage system, assist provider with the chest tube insertion, encourage coughing and deep breathing. What is the first thing you're going to do? Arrange them in order. I got to verify the orders. I got to prepare for the chest tube system. I got to assist the provider, apply occlusive dressing, and let the patient take a deep breath and cough after the procedure. And next is walking in into a client's room, having a jerky rhythmic body movement in the bed, seizures. What is the next first action? You walk into the client's room and you're having seizures. What do you think? What do you think? This one said, hold the client down the legs. So hold down the legs. It does not show up. Hold down the legs. Place a small pillow under the head. Place the client in the left lateral position. Open the mouth and insert the mouth guard. Patient is having seizures, as you expect. What would you do? Protection. Nothing through the mouth. Don't do anything. Before you put a small pillow under the head, place them on the lateral side. This is to prevent injury. After a workshop on how to set up a sterile field, which order should the new graduate place the following steps to set up a sterile field? How do you set up a sterile field? Which one would you do? Open the sterile item, gather all equipment, dispose of the packing, and drape the sterile field. How do you arrange them? I make this question to let you know NCLEX is unpredictable. You go and you see this, you think they're killing you. No, you're doing great. You just have to stay put, take a deep breath, stop the video, go get something to drink, come back, and you said, I got this. Don't sit there. This is number 40. If you take in the NCLEX and you see this, I want you to stop and say, no. Take a deep breath and come back. Don't panic. What will you do? Of course, there's no equipment procedure, you don't gather things. After you gather yours, you drape your sterile field. Then you open your stuff and then you dispose of the package. That's all. A new graduate file incident report to the client after a fall. This is the safety questions we have to get to. You know, we are now in safety. Okay, the infectious control, risk reduction, fundamentals, next generation class. Now we are on safety. NCLEX safety questions. Which component of the report need further teaching? Incident report. What should you include? Statement where in quotation mark, detailed explanation for the cause of the fall, name of the witness, and intervention administered. Which should you include in what? Incident report, and which one need further teaching? I can tell you, No, you don't need a detailed explanation for the cause of it. You don't know. Patient fell. This is what I see. This is what it was intervened. And then this is what the witness intervention apply and the statement in quotation mark. Don't need to explain everything. You may cause more problem. Your opinion does not matter. Factual information and let the people do the investigation. No, mostly factual information. No subjective data. Subjective is you explaining yourself. Objective, everything quiet. And next, prepare to transfer a client from the bed to the chair. Go into the bed to chair. Which body mechanics action by the nurse is appropriate? If I'm transferring the patient, what do I need to do to prevent injury? Nurse knee kept bent, client body close to the nurse and facing away. Nurse maintain straight neutral back. Nurse assume a wire-based stand. No twisting or rotation at the trunk. 1 foot of the nurse slightly in front of the other, and rotating and bending movements were combined. Stop the video, pick your answer, keep track of your score. You got it. Number 42. Hey, it looked intimidating, confusing. Done. You want to transfer the patient. Picture yourself. What actions will you take to prevent injury? Number 42. Make me proud. You're going to bend yourself, right? Bend your knee. Client body close to the nurse and facing away. That's unsafe. The nurse maintains straight back. You don't want to break your spine. The nurse assume wire-based stand to help you not to fall. You don't twist or rotate at the trunk. That's why you keep your straight back straight. 1 foot of the leg slightly in front of the other. That gives you a better, and you don't rotate any movement on your spine. This is what you should know. You can take a picture, but this is the best way, proper body mechanics in transfer. While base, bend at the knee, 1 leg in front of the other, nurse faces the client at all time, no twisting or rotation at the wrist, and neutral position is always the best way. Caring for a client who is post-knee arthroplasty and ready for discharge, which teaching by the nurse is indicated or not indicated for home safety. Like I said, safety question, patient is going home, he has knee arthroplasty, that means knee surgery, knee replacement. Which one will you institute for safety? Use injectable enoxaparin as needed, use a wheelchair to assist with ambulation, install a grab bar in your toilet, install elevated toilet seats, take Motrin for cramping pain in the calf. What do you think? Which one is indicated or not indicated? Is this indicated? Of course, yes. They will need to inject enoxaparin to prevent DVT. Use a wheelchair to assist with ambulation. No, you should be walking. You should not use the wheelchair. Use a grab bar in your toilet so that you don't fall. Excellent. Elevated toilet seats, same thing. You don't fall, you don't rotate on your hip. And Motrin for calf pain, it may be DVT. This is not indicated. If you have cramping pain in your calf, let the doctor know. Maybe DVT. A nurse is preparing to administer medication to a newborn. Which intervention is most important to administer to minimize the risk of drug toxicity? We move to pharmacology. And pharmacology, I know you got it. This is a newborn. We're going to give you newborn medication. Which intervention is important to minimize the risk of drug toxicity? Shorten the interval between medication dose, monitor the newborn urine and kidney function, double check the dose with another nurse before giving, give the medication by the fastest route possible. There's a concept there. Pick your answer. Let me know. But I can tell you, a newborn, the liver and the kidney does not work. Therefore, if you give them medication, the half-life, you want to give them something that lasts, that you don't have to give them more frequent, right? Because they take them a long time to clear it. You got to check the liver and their kidney. Therefore, checking their urine output is the best thing. Shortening the interval will cause toxicity. Double checking with another nurse is not going to help because the patient is the major problem. Giving the fastest route is a problem. You want to give them slow as much as possible. A child receiving IV acyclovir for herpes simplex infection should be monitored closely for what? Acyclovir is antiviral. What is the major side effect? Renal toxicity, bradycardia, hearing loss, hypertension. This one, if you know it, you know it. Pharmacology is something, if you know, you know. You see it, acyclovir, there should be one word coming to your mind. Whenever you see acyclovir, it affects your kidney. It's very nephrotoxic. Therefore, you got to drink a lot of water. And this is teaching the client about safe use of transdermal fentanyl patch. The fentanyl does not matter. The patch is the key. Which of the following statement indicate correct understanding? Select or apply. It's a patch. Every question, think about it in the patch form. I will apply the patch to the clean, dry, airless skin. I can cut the patch in half if the full dose is too strong. I should rotate the patch site with each application. Heat, like a heating pad, can increase absorption of the patch. I will fold the patch and flush it down the toilet when I remove it. I should report difficulty breathing, excessive drowsiness immediately. What do you think? Pick your answer. Think about it as patch form. But at the same time, if you see something related to fentanyl, then pick it. Patch should be applied to clean, airless skin. Don't cut the patch. You should rotate it. You should not apply any heating pad. You should fold it and flush it down the toilet when it's removed. And I should report difficulty breathing, excessive drowsiness immediately. These are the things you should do with the patch. Which of the following medication should never be administered via IM? Lorazepam, Heparin, Allopurinol, diphenhydramine. What do you think? You pick an answer. Number 47 is heparin because it causes bleeding. All these things can be administered IM. And next is preparing to administer digoxin to adult client. Which of the following actions are appropriate? Select or apply. Hold if apical pulse is below 60. Give with antacid to reduce GI upset. Assess potassium level before administering. Notify provider if client reports seeing halos. Administer even if the heart rate is irregular. What do you think? 48. Stop the video. Pick your answer. Concept, digoxin. I want to give it to an adult patient. What do you need to bring your content and answer it? I know you got it. Pulse, apical pulse less than 60, you should hold it. You should not give them antacid to reduce GI upset. If I see GI upset, toxicity. Assess potassium level before administering. If it's low, it can cause toxicity. If they start seeing halos, that's the problem. And you still have to give it to them. Even if they have AFib and irregular, you still give it to them because it's mostly going to help with the rate control. But the rate is fine, but they can have irregular rhythm, but the rate should be fine. Which action by the nurse demonstrates the sixth right of medication administration, asking the client's roommate to confirm their identity. Is that sixth right of medication? Give medication for memory without checking the MR. Verifying the client's name and the date of birth with the MR before administering. Administering medication 2 hours after the scheduled dose. Which one is consistent with the medication administration consistency? Of course, you got to verify the name, information to verify before you give it to the patient. 2 hours too late is not good. The client with sertraline is prescribed which new medication when in the next question? I'm taking sertraline. If you're taking one of this, you should do what? Question. It's 50. Sertraline is an SSRI. That means you should not take any SSRI. Do you see any SSRI there? Like you said, stop the video, pick your answer, let me know. Which one is an SSRI or has serotonin agonist associated with it? Serotonin is an MOI, serotonin, terminal, bind to serotonin receptors. St. John's what? Serotonin. What do you think? Metformin does not do that. Sumatriptan also a serotonin agonist. All these things you should avoid when you're taking citrulline. A client who is taking triflin is prescribed what? A new prescription, the next question. That means you shouldn't take this medication together with triflin. Ciprofloxacin, albuterol, caffeine tabs, cimetidine, metoprolol. There's a concept here. Pharmacology. If you need more, check Adaptation class. A bunch of pharmacology free case studies, English questions that will make this question easy for you. There's the thing I say whenever you see triflin, write the 4 C's. Cirrhosis, that's the liver. So no alcohol. Ciprofloxacin, cimetidine, and what? Coffee-related product. Therefore, you get the answer? I know you got it. Ciprofloxacin, bad. Albuterol, yeah, you can give it to them. It's a short acting. Caffeine, yeah. Cimetidine, yeah. And metoprolol, what do you think? Metoprolol, what do you think? It's fine. Expected finding. It does not affect it. A client taking methotrexate for rheumatoid arthritis, which prescribe new medication, and next question, selected apply. If you have rheumatoid arthritis, you're taking methotrexate. What do you think? Sulfametazole, trimethoprim, folic acid supplement, ibuprofen, prednisone, and aspirin. If you take methotrexate and you take sulfa drug, especially this, sulfamethometazole, trimethoprim, is going to worsen the activity of it. The folic acid supplement is going to help you what? Prevent the toxicity of the methotrexate. Ibuprofen worsen the effect of methotrexate regarding to your kidney, and aspirin. But prednisone can be taken together, immunosuppression. This is our pharmacology. They look odd, but that's the thing. Hard pharmacology, think about it. And this is administering Pitocin infusion to a laboring client, which assessment finding require immediate intervention. If I give you Pitocin, cervical dilation, 6 minutes, maternal blood pressure of that, your contracting lasting 95 seconds, and fetal heart rate is 45. Which one is bad? Your contraction should not last more than 90. This is 95 seconds. We should intervene. A client with ICP is receiving Mannitol. Which finding require immediate intervention? What is the major side effect of Mannitol? Increased urine output, serum sodium of 145, crackles in your lung, and blood pressure of 130/80. What do you think? Pick your answer. Let me know. But the concept is if I give you Mannitol, it's going to pull fluid from your brain into your intravascular system. Where would the fluid go? It go to your lung. Therefore, crackles is bad. Your urine output is going to increase. Your sodium may increase because you're losing what? Fluid. Your blood pressure is normal. Another case study. Are you ready? I know you got it. Client is alert, completely oriented. Mood is flat. He's pacing and cannot stay still. What is the problem? He's complaining of what? Inner feeling of restlessness. That's the buzzword. He has no suicide, no pressure speech, no grandiosity. The report slight headache. His lung is clear. X1, S2 present. Abdomen, everything is fine. You take what? Respirator, Digoxin, and lisinopril. What do you think is going on? Report what? Pacing and cannot stay still, inner feeling of restlessness. And next, as you review the clinical data, which condition the client is most likely experiencing. Look at it again, stop the video, play it, and watch it. What do you think is going on? I take respirator, Digoxin, lisinopril. All of a sudden, I'm pacing, I cannot stay still, inner feeling of restlessness. I have no suicide. I have no process speech. I have no grandiosity. What do you think? It is the bipolar, akathisia, hyperthyroidism, or attention deficit hyperactive disorder. This is what? What do you think? What do you think? This is a bow tie question, bow tie English question. This is akathisia. Bipolar, I will tell you as pressure speech, grandiosity. Hyperthyroidism, I'll tell you the eating, losing weight, everything is up. Attention and deficit hyperactivity will be young. I have to explain he has problem at school and everything. There's no evidence of that. Therefore, what are you going to do? Give them diazepam, propranolol, metamizole, and methylphenidate. It's easy, right? Look at it. I'll show you how to answer them. ADHD, you use that one. Hyperthyroidism, you use metamizole. If you have to pick two, it's that. And then you just follow the patient. We're not going to worry about your weight. We're not going to worry about your growth retardation. I got to worry about this. This is how you answer both type questions. Straightforward. If you pick akathisia, diazepam, and propranolol, and anxiety and strain with dysphoria is what you're going to worry about. Growth retardation associated with ADHD. Weight loss is associated with ADHD. And then hyperthyroidism is associated with weight. Therefore, this one, we give them that, and anxiety and euphoria. Number 56, we are on cardiology. And the first question we have is what? EKG. And this is assessing a client in emergency department. The nurse observes the rhythm below on the cardiac monitor. Client has what? No chest, no complaint. What is the nurse first action? Adenosine, diltiazem, metoprolol, atropine. This is what you see. Client is a nurse is assessing the client in the emergency room. The nurse observes the rhythm below. The client has no complaint. Is this normal? I can tell you it's not normal. If this is not normal, it's more than sinus stack. This is what we call SVT. If this is SVT, what is the treatment for that? Adenosine is your best answer. Even though that the diltiazem, metoprolol will work, they are not the best choice. Atropine will speed up the heart. It's not good. And let's provide care for a client with this rhythm on a cardiac monitor. What is the next first action? You see this. What do you see? This is slightly different from what we saw. You see there's M's. The first one we saw only one pick. This is sinus tachycardia. You sinus tachycardia, what do? Immediate CPR, what? Synchronized cardioversion, assess temperature or metoprolol. What will you do? Patient has tachycardia. What is the best choice? You should figure out what is wrong with the patient. Is it temperature, pain, dehydration? All this thing is not needed if you have sinus tachycardia. And let's provide care for a client with this rhythm. Client has no pulse. That means I have this and I have no pulse. That means I'm dead. It's the same thing as asystole. If I have asystole, what do? Check the client pulse. I just told you no pulse. Immediate synchronized cardioversion. It just has no pulse. Immediate CPR, defibrillation, CPR. And next is caring for a client who has what? Frequent PVC on the monitor. What should the nurse do first? Administer a dose of prescribed amiodarone, assess the client blood pressure and oxygen saturation, notify the healthcare provider over the frequent PVC, prepare the client for immediate synchronized cardioversion. PVC, what should be your next action? It's a warning sign. See if it's affecting the client's hemodynamics to protect their blood pressure and oxygenation. Prescribing amiodarone, you're just treating the problem. Calling the provider, you don't know, you have no access to the patient. Immediately cardioversion, this rhythm does not need cardioversion. And this is assessing the client who has no pulse. There's no pulse. It's unresponsive with this trip. And you started with the CPR for 2 minutes. No pulse. This is the rhythm. Flat. Asystole. and you've done CPR for 2 minutes, what action should you take? Defibrillate, synchronize cardioversion, administer 1 milligram of epinephrine, and then give them atropine. So patient has no pulse. He has this flat rhythm. That's asystole. What do? You know this is not a shockable rhythm. So for defibrillation, synchronized cardioversion is gone. It's mostly medication. And the best medication is speed up the heart. That's what? Epinephrine. For each potential intervention, click to specify if this is indicated or not indicated. What do you have? This is the condition. A 65-year-old client is admitted to the cardiac intensive care unit following an acute myocardial infarction. He has a what? History of hypertension and hyperlipidemia. Upon admission, he appeared alert but fatigued with what? Mild dyspnea. The client report what? Diaphoretic, visibly anxious, report worsening shortness of breath and chest tightness. This is vitals. Heart rate of 12. Blood pressure, hypotensive. Saturation 91.2 liters. The cardiac monitor suddenly display what? Y complex tachycardia. All of a sudden, patients what? VTAC. The nurse immediately assess the cardiac pulse and find none. There's no pulse. The client become unresponsive. What would you do? This is next generation standalone question. Patient came in, he has MI. All of a sudden, we are assessing them VTAC, no pulse, and then boom, unresponsive. Read it again, find the bias rate, know what is wrong with the patient. What would you do? You have an unresponsive patient with a VTAC, no pulse, pulseless VTAC. After MI, what is your step? Administer oxygen via nasal cannula. No, this patient needs something to be bagged or intubated. Of course, we're going to call a code. Perform synchronized cardioversion. No, because patient has pulseless VTAC. This is not indicated. Defibrillate the client immediately. Yes, pulseless VTAC. Start high quality CPR. VTAC, pulseless. Check cardiac pulse with each compression. This is it. Concept. Watch it again. These multiple times. When the NCLEX give you this standalone, don't be defeated. They are straightforward. Read it. Figure out what was wrong with the patient. We have pulseless VTAC. This is what we see. An experienced UAP recording the heart rate of 110 to the client. The client ordered say to report any heart rate greater than 100 to the healthcare provider. Which action should the nurse take? Report the finding immediately to the healthcare provider. Check the client lab work. Review the client lab's medication administered. Assess the client for any symptoms. Rewrite the question. Figure out what is going on. UAP recorded heart rate of 110. There's an order saying if the heart rate is greater than 110, the nurse should call. What should you do? You should assess the patient for any symptoms. Then you call the doctor, let them know. You should not use the RN, the UAP vitals and use it alone and call the doctor. Figure out if there's something wrong with the patient, not just the vitals. And this is admitting the client to the post-anesthesia care unit to just receive what? Pacemaker for heart block. This is cardiology, NCLEX practice question. Which action should the nurse prioritize? Assess breath sound, assess the insertion site for bleeding, capture the heart rate set for a pacemaker, initiate the prescribed antibiotic. Patient just a pacemaker. What should be your prioritize? You got to make sure it works. Therefore, which one? Make sure it can capture. If it doesn't capture, you should let the doctor know. Assessing breath sound, that's not a priority. It's a trap. Assessing the insertion site for bleeding, it's a trap. If the pacemaker does not work, we are in trouble because we are in PACU. And this is assessing a client with cardiac tamponade. Click to specify the finding that is expected. What do you know about cardiac and tamponade? which of this is expected finding for a patient in cardiac tamponade? That means there's fluid around the heart and it's pushing on the heart. There's certain 5 things you need to know about cardiac tamponade. That is the concept, and this is cardiology. Bradycardia, crackles at the lung base, hypotension, JVD, bounding peripheral pulses, pulses paradoxical. Stop the video, pick your answer, let me know. But I can tell you, you're going to be tachycardic, not bradycardic. Crackles in the lung base, it has nothing to do with your lung, unexpected. You're going to be hypotensive, expected. You're going to have JVD, expected. Pulses is going to be weak, no bounding, and you're going to have pulses paradoxical. Concept, cardiac tamponade, know it. The client is in septic shock, is on norepinephrine with the map of 65. That's good. The next, note the following. Blood pressure is low, map of 52, heart rate of 110, lactate of 5.2, right? This is where we want to go. Map of 65. We low. Our blood pressure is low. We lactate is low. That means we stay in shock. If I'm staying in shock, what would I do? Increase norepinephrine infusion, administer 500 normal saline, obtain ABG, and start dopamine. Think about it. Septic shock is on norepinephrine to maintain it, and this is the vitals we got in. What are we going to do? Think about shock. If I'm in shock, norepinephrine is not going to help me that much. I got to fill the tank and squeeze fluid. ABG is not going to help me. Dopamine is the same thing as norepinephrine. Therefore, that's your right answer. And let's provide care for a client with the new diagnosis of Crohn's disease, endocrine. Like I said, we're going through every little one of them so that you can master them. Crohn's disease, which finding the name you expect? Hypokalemia, hyponatremia, hypotension, headache, metabolic alkalosis. What do you think? Crohn's disease, it means too much aldosterone. If you have too much aldosterone, potassium is going to do what? Think about it. It's going to go down. Sodium is going to go up. Your blood pressure is going to go up. You're going to have headache, and you're going to have metabolic alkalosis. And this is provided teaching to a client prescribe what? Levothyroxine for hypothyroidism. Which teaching is appropriate? Select or apply. Hypothyroidism, how do you take it? What teaching you should provide? Take the medication with an empty stomach. Take medication in the morning. Remain upright 30 minutes after taking the medication. Add omeprazole to the pill to ensure fasting absorption. Take the medication with full glass of water. This is always a common NCLEX question. You have to know how to teach the patient about levothyroxine and what they need to do. Stop the video, pick your answer, number 67, and let's see where you got. The way to take this medication is an empty stomach, early in the morning. Remain upright. Antacid will affect absorption, and you take it with a full glass of water. A client arrived in the emergency room with mesothelioma coma, endocrine, which assessment finding by the nurse is most concerning. Mesothelioma coma is severe hypothyroidism. Therefore, you know hypothyroidism, everything goes down except your weight. Therefore, which one is bad? Respiratory of 12, blood pressure of 57 or 45, temperature of 95, confused, and does not follow command. This is a trap. But which one is the worst? Pick your answer. We only have 6 more questions. Even though all of this, 12 is within normal limit, confused does not follow command is bad, hypothermia, if your heart doesn't pump, you'll be dead. And this is the worst. Severe shock. It's almost like it's in tamponade. No pulse pressure. That's bad. And then provide care for a client with syndrome of inappropriate secretion of ADH, which action is a priority. Retention of fluid. If you retain fluid, what is going to happen? Bed in the lowest position, check serum sodium, check urine specific gravity, administer oxygen, which should be your priority. they're going to have seizures because low sodium. I'd rather do this. That does not require lab work rather than checking sodium, because that's the major problem. They're going to have seizures, and therefore bed in the lowest position is something you should prioritize. It's a SIDH leads to hyponatremia, a major cause of seizures. Therefore, seizure precaution should be initiated first, bed in the lowest position before you check sodium. And let's provide care for a client with asthma, respiratory problem, respiratory NCLEX question. With the new diagnosis of hypertension, I have asthma, I have hypertension. Which prescription should the next question? That means if you give me this medication, it's going to affect my asthma. Atenolol, Nadolol, Metoprolol, Motrin, Acetylcysteine. Which one should I question? Pick your answer. Don't forget this. BAM. Bisoprolol, Atenolol, Metoprolol, safe with asthma, because they are selective beta blocker. So Atenolol is fine, Metoprolol is fine, but Nadolol is not. Motrin causes polyp, acetylcysteine causes bronchospasm. Those are a bad problem. Asthma patients should not take it. 3 more questions, then we're done. Because of the case study, we have almost done. And let's provide care for a client with tracheostomy who needs suctioning. Which action the nurse should take first? If you have to suction the patient, do you insert the suction without pressure? Pre-oxygenate with 100%. Suction client mouth first. Ask the client to take a deep breath for 10 seconds. What is the best thing you should do? You should pre-oxygenate the patient. 2 more questions. And nurse is assessing several clients about asthma using peak flow meter. Which action by the nurse is appropriate? Instruct the client to wait 1 hour before going to the emergency room with persistent what? Red zone peak reading after a rescue agent. Nurse instruct the client to wait 2 hours before notifying the healthcare provider with persistent yellow zone peak flow reading after rescue agent. Nurse instruct the client to notify the healthcare provider when yellow zone reading change to green after the rescue agent. And then nurse instruct the client to take oral steroid, continue the rescue agent, notify the healthcare provider after yellow zone peak reading following despite inhale rescue agent. A bunch of words. Why did I do that? To confuse you. Because that's what the NCLEX will do that. But what you need to do, divide the zone, see red, green, yellow, and red, and see what you need to teach them. That's all. You don't have to worry. Just divide it and see what you need to teach them. I can tell you the right answer is this. You instruct the client to take steroid, continue with the rescue agent, and notify the healthcare provider because they are in yellow zone. They don't need to go to the emergency room, right? Despite inhale rescue. So they need to follow up, right? Instruct the client to notify the healthcare provider when the yellow zone changes to green. After yellow to green, you're good. After you take albuterol, that means you're good. Next, instruct the client to wait for 2 hours before notifying the healthcare provider with persistent yellow zone following reading. That's not appropriate. And then instruct the client to wait 1 hour before going to the emergency room with persistent. You should go to the emergency room right now. And the last question, 73. Total of 85 if you count the case study. And then provide care for a client diagnosed with what? Obstructive sleep apnea. Which finding is consistent with the diagnosis? Select and apply. Excessive daytime weakness, morning headaches, loud snoring, apnea for 10 seconds or more, and sore throat. Obstructive sleep apnea. What do you think? Excessive daytime sleepiness, not awakefulness. They're not going to be awake. They'll be sleeping. They have morning headache. They have loud snoring, apnea more than 10 seconds, and then sore throat. NCLEX practice question, NCLEX review question, NCLEX questions and answers. 85 questions commonly tested that you will see on the NCLEX using common sense NCLEX questions This is Adapting Class. If this video helped you, and if you get to this end and you've achieved a 65, thank you for watching, and share with your friends. And if you have not subscribed, just click on the subscribe button and click a click note and help us grow. Thank you and good luck.